Hello and welcome to the webinar. My name is Erica Burrows-Girardi and I'm a community coach with County Health Rankings and Roadmaps. Today I'm joined by my colleague and fellow community coach, Mary Bennett.
Hello, I'm happy to be part of this webinar and I'll be helping to answer your questions as well as sending some links out via the chat box throughout the webinar.
Mary and I are excited to have David Ciccone with us today to talk to us about an innovative social service model being implemented in Franklin County, Ohio. Welcome, Dave.
Hi, Erica. Appreciate being here.
Great, thank you. First, we'd like to acknowledge the important relationship we have with the Robert Wood Johnson Foundation. The County Health Rankings and Roadmaps program is a collaboration between the Robert Wood Johnson Foundation and the University of Wisconsin Population Health Institute. Next, we want to take a moment to get you oriented to the technology we're using today. The GoToWebinar attendee interface is made up of two parts. On the left, you can see the viewer window where you will see our screen throughout the presentation, and on the right, you can see the control panel. You can interact with us through the control panel by using the question section. Please feel free to ask questions or share your thoughts and experiences with us via the control panel throughout our webinar today, and we'll be sure to leave time for your questions. Now, just above the question box, you will notice a handout section. Mary has placed two handouts there to provide you with more information related to today's webinar content. This question guides our webinar today. How can social service providers collaborate more efficiently to help those most in need? We'd love to hear your examples. Please use the question box to share with us what has worked well in your community, and be sure to include the name of your community so we can share with others on the webinar. As we move into the real content of the webinar, we'd like for you to consider these questions as you listen. Who else do you need to share this information with? What is one idea for action that you're taking from this webinar? And what else do you need to know to take action or use this information? We'll start with a brief program overview to ground our discussion in County Health Rankings and Roadmaps. This will take about 5 minutes. If you're newer to us, this will give you a high-level overview of County Health Rankings and Roadmaps, but to learn more, we encourage you to check out one of our Rankings and Roadmaps one-on-one webinars. Mary will be chatting out a link to our most recent recording. The County Health Rankings ranks the health of nearly every county in every state. For each county, you will find two rankings, one for health outcomes and one for health factors. This image shows the relationship between policy, health factors, and health outcomes. It illustrates why it's important for communities to take a broad definition of health. Many factors impact how well and long we live. Things like how we commute to work, housing conditions, access to parks, the quality of our schools, access to healthy foods, community safety, and even our social connectedness all impact our health outcomes. So what does this image tell us? Well, starting from the bottom, we know that effective local, state, and federal policies and programs can improve a variety of factors that in turn shape the health of communities. There are many health factors that shape our community's outcomes, our health outcomes, and we specifically look at health behaviors, clinical care, social and economic factors, and physical environment. We measure two types of health outcomes to show how healthy each county is: length of life and quality of life. Today's webinar focuses on social and economic factors, particularly family and social support. And we'll hear from David Ciccone about the United Way of Central Ohio's work with family and social support. Dave, as you take a look at our model, I'm sure that you notice several areas, including family and social support, where you see your work. What other areas could you highlight for our participants?
Sure. Well, in addition to family and social support, I definitely see links to our work in the areas of access to care, diet and exercise, education, employment, and housing. And as we'll discuss later on in this webinar, we've tried to achieve a level of integration across some of the key factors our United Way is addressing in Central Ohio and Franklin County.
Wonderful. Thanks for sharing that. So these are just some of the reasons why family and social support is important to health. People with greater social support live longer and healthier. People without social support experience more stress, leading to poor health. And supporting relationships between individuals and across entire communities can benefit health. That's why I think you will find an innovative approach that the United Way of Central Ohio has used to provide social services to their community to really be informative. Let's take a closer look at what we measure related to family and social support in the county health rankings. If you were to visit your county snapshot, you would notice these measures associated with social and economic factors. While many of these are related to family and social support or might in some way impact it, the two that specifically are used to measure the focus area of family and social support are children in single-parent household and social associations. The Take Action cycle is the how within rankings and roadmaps. It lays out the process communities follow to improve health. Within this process are several action steps, including gathering information to assess needs and resources, setting priorities so you can focus on what's important, finding the most effective approaches to address your priorities, and then getting to work on acting on what's important. And of course, evaluating throughout the cycle will help you improve your strategies and ensure that what you're doing is effective. You'll see that communicate and work together sit outside the cycle because working together and communicating with stakeholders is essential throughout the Take Action cycle. And at the heart of the Take Action cycle is people working together, because we know that solving issues like childhood obesity, poor high school graduation rates, or crime and recidivism require the wisdom and resources of everyone in the community. The Roadmaps to Health Action Center includes guidance and tools to help communities keep moving along this cycle. Mary will be sharing some links to some relevant tools to these guides during today's webinar, and they'll also be posted online later this week. Now, we know that implementing any type of community change model is a lot easier said than done. So here at County Health Rankings and Roadmaps, we have community coaches who provide community leaders with direct support to strengthen their capacity to advance health improvement efforts in communities. Our coaches use the County Health Rankings model and the Take Action cycle as frames for their guidance. We can also guide partnerships in the use of the Action Center's many practical tools and resources. To connect with a community coach, simply click on any of the peach Get Help buttons that you will find throughout our website. So, how do you begin the process of choosing effective policies and programs? We're all very busy, and it really doesn't make a lot of sense to reinvent the wheel or waste time implementing strategies that just aren't impactful. What Works for Health provides communities with information to help select and implement evidence-informed policies, programs, and system changes that will improve a variety of factors we know affect health. Strategies are rated based on their evidence of effectiveness. What Works for Health includes 6 different ratings ranging from evidence of ineffectiveness to scientifically supported. From our What Works for Health page, you can click on any focus area of interest. So for today's webinar, we would click on Family and Social Support and discover that there are 25 policies and programs filtered by family and social support. One of the strategies you will find here is social service integration. In a moment, we'll hear from our guest again about the United Way of Central Ohio's experience implementing a social service integration model to serve individuals and families in Franklin County. And by the way, that is where the capital, Columbus, is located. So with that, I am pleased to welcome again today David Ciccone, whom we call Dave. Dave is an Assistant Vice President of Community Impact and Senior Impact Director of Health at United Way of Central Ohio. He facilitates planning and process to guide the structure and role of community impact investment as part of United Way's strategic organizational framework. He manages cross-functional projects and activities designed to support all aspects of United Way's work related to health. This includes facilitating collaboration among community agencies, donors, and other key community stakeholders around the development and implementation of community impact strategies. Dave holds a bachelor's degree in psychology from the College of Worcester in Worcester, Ohio. He's married to Megan, and together they are raising 2 young children. Dave, welcome again, and I really appreciate you taking the time today to talk to us about this social service model that's really helping to change the way services are being delivered in Franklin County and particularly Columbus.
Yeah, thanks again, Erica. We're excited about this work. It's new and emerging for us, so we're in both an implementation and an ongoing learning mode. So look forward to sharing our experiences today.
Great. So with that, let's just go ahead and jump right into the content that I'm sure everyone's been waiting for. I understand that one of the United Way's goals is to lift people out of poverty. Can you start with giving us a brief demographic picture of those living in poverty in Franklin County?
Sure. As you mentioned, Erica, Franklin County is in the central part of the state. Columbus, Ohio is the county seat, so it's a fairly large metro region within our state. Its metro population is about 1.3 million residents, and within the city of Columbus, probably about 800,000 to 900,000 residents, just to kind of give the listeners a sense of the region and the community in which we're located. Central Ohio is both a vibrant region with many strengths and a lot of tremendous opportunity, but like many other communities with demographics like ours, it experiences a fair bit of challenge as well. And one particularly challenging trend within our community is, like others, we've experienced the after effects of the economic recession since 2008 and 9. And we're fortunate that while our unemployment rate, which reached a high of about 8.6% in 2010, it's declined significantly. The unfortunate other side to that trend is that our poverty rate has not. While in 2010, both our unemployment and our poverty rate hit their highest in recent times, the poverty rates have stayed stubbornly high. So we're seeing folks in our community who are at or below 200% of the federal poverty level at about 9.5% of our county population. So this is obviously a concerning trend, and it's a persistent one. And so as you can see from this slide, folks that are residing in Franklin County and are experiencing issues related to poverty are younger, they're more diverse, they're more likely to be disabled. Poverty is more concentrated in immigrant and new American populations, and we're seeing particular concentrations of poverty within very distinct neighborhoods, metro, central city neighborhoods within Columbus, Ohio and Franklin County. And so our leadership, both board and staff, has been pretty clear that while we've had a focus on addressing health and education and workforce and housing related issues, these persistent trends related to poverty we're going to continue to hinder our efforts to be able to make any meaningful progress to address those particular community needs.
So how has the United Way responded to this economic landscape and those challenges that you're talking about in Columbus to help support families?
Sure. Well, as I mentioned, like many United Ways within our network, we've had pretty clear organizational priorities or community impact priorities, and so they've centered around addressing health and education, workforce and housing related issues. But as I said, our leadership and many of our stakeholders made it clear that the persistent trends related to poverty in our community were going to continue to hinder and really limit any kind of impact we were able to achieve unless we placed a more direct focus on poverty and the root causes of poverty. So our organization adopted a new strategic plan that went into effect in 2014, and it was a pretty clear, pretty singular focus on addressing the root causes of poverty and helping to create pathways out of poverty for those most affected by it. Our strategic plan focused much of our work. It aligned all of our investments and our allocation of resources on community impact activities focused on creating pathways out of poverty. It emphasized greater coordination among community systems and stakeholders, and it stressed leveraged investments and a more integrated approach to our work. So really it was as a part of adopting and embracing this new strategic direction that our team was introduced to the Pathways Community Hub model, and that's where really we began a pretty earnest investigation and exploration of the model.
So the Pathways Community Hub model is a social service integration approach. And how did your stakeholders influence the development or the fleshing out of this model?
Sure. You know, later on in our conversation, I'll share this as a key learning, but I'll reference it now and share that you know, our exploration of the hub model involved a pretty lengthy set of conversations. So we visited with a variety of different stakeholders. I think our tally of conversations is somewhere between 70 and 80 individual stakeholder conversations over the course of about a year and a half, just to sort of explore the value of this Pathways Community Hub model, and just to get a sense from stakeholders, you know, whether or not this approach to the work would add value in Franklin County and Central Ohio. And as this slide depicts, 4 pretty clear perspectives and themes continued to recur. You know, one, within our current health and human services system, you know, it was clear that people in need face complex and interconnected issues, and they seek help from multiple sources within our community. And providers, both health and human service providers, recognize that they're dealing with these multiple co-occurring client needs and try to address them in as effective way as possible, but you know, they too acknowledge that they're dealing with limited resources and really limited ability to be able to coordinate across systems. And funders, investors acknowledge that you know, there's sometimes question whether there's duplication of investment or redundancy in services, and whether we're getting the most effective return on investment through public-private funding. And ultimately, we heard that you know, our community is not achieving the individual and population level outcomes that we want. So, you know, on this slide we show that in our community we know 1 in 5 people are living in poverty and dealing with the issues that that go along with it. So essentially what we heard from each of these 4 perspectives is that our health and human service system, while relatively well resourced, isn't necessarily meeting stakeholder needs in the way that it's currently structured. And so this is just another sort of take on that same set of observations that came from our stakeholder conversations. This is essentially this is our illustration of what we heard that the health and social service system feels like to the different perspectives of folks that we talk to, clients, funders, providers, and sort of, you know, our community at large. And so while we're fortunate, I should be clear in saying that in Central Ohio there are pretty sophisticated and really well-resourced services and systems and institutions within our community that are well-positioned to meet a lot of individual need. But what became clear to us is that we don't have the adequate coordination or perhaps infrastructure that supports that coordination. So it isn't really about investing more money, more resources into the system, but really, you know, finding an approach to the work that could help catalyze more effective and more consistent coordination across and among systems. So, you know, again, this sort of illustration of our system looking a bit fragmented and perhaps performing below its potential.
Yeah, that's actually quite common. What types of services can your customers be connected to through the Pathways Community Hub?
Sure. So as we as we get into the model, I want to make the point of saying that really this Pathways Community Hub model and the approach to this work is based on a fairly straightforward concept. It's based on the idea of connecting people to services, or really community-based care coordination. And this slide depicts the major elements of that. It's really about finding and identifying need and assessing that need early on, and through consistent ways of assessing, to be able to provide ongoing care coordination services and to really focus on connecting individuals and families with the resources and supports that can meet their needs, and to measure outcomes in an accountable way. So you know, I want to sort of make the point that it's based on a fairly straightforward concept. Some folks may know this as case management or linkage and referral. It's sort of based on that same concept. And in this slide, you know, just to sort of talk through a brief example to level set for listeners, you know, the approach to the work here is depicted by perhaps assessing developmental need within a preschool child, perhaps a 2 or 3-year-old, and so doing that through what's common in our community is an ages and stages developmental questionnaire. And so what might surface from that assessment is developmental need that could be addressed through remediation services and referrals. And so what the model does is it instigates a more thorough, comprehensive assessment of the child and of the family, sometimes in the home. And what may surface from that more comprehensive assessment are other family needs that extend beyond that of the preschool child. Perhaps the father is dealing with an unemployment situation and some employment-related barriers to getting and keeping a job, and perhaps the mom may be well into a pregnancy, perhaps first or second trimester, but may not be connected to a regular source of care or prenatal health care provider. This model of community-based care coordination instigates care pathways, or you know, care management protocols for each of the co-occurring needs of the individuals in the family, and it provides ongoing support and accompaniment through those care coordination protocols toward resolution, to make sure that the child is connected and involved with, let's just say, social emotional early learning remediation services, and the mom is connected to a prenatal OB provider, and then the father is connected into workforce training and development resources to be able to get him back connected to the workforce. So that's really the basis of the model.
Mm-hmm. So we see that the hub is one way to influence greater coordination and integration among those various social services. And I want to remind our audience that social service integration is a suggested strategy within What Works for Health. You can explore that more in What Works for Health. And it is suggested as a way to improve access to social services, just as Dave is describing right now. Dave, I think what our audience would really like to know is, how is the hub increasing efficiency in service provision and demonstrating the potential to achieve improved outcomes?
Sure. Well, again, I sort of I hinted at this characteristic relative to our community, and I suspect that it may be in place in other communities outside of Central Ohio and our state. But the hub model builds on the assumption that there are already a number of really well-functioning services and supports that exist in our community. So to that end, it doesn't necessarily put in place another competing program or an initiative that could create the potential for additional duplication or service redundancy. Rather, what it does is it establishes more predictable, organized activities across a network of service providers, and it emphasizes increased efficiency, which over time would influence improved outcomes, and ideally, over time, the opportunity to be able to reduce costs within our system. And it really does so because it relies on organizations that are already well positioned to do this work within our community, and it positions the hub model as an intermediary between funders and payers, and a more coordinated network of community-based care coordination service providers. So I'll take us into the next slide here. This is an illustration that we've used, and that's been really helpful for partners in our community to become sort of socialized to the Pathways Community Hub model to get a bit more familiar with some of the elements of it. And so over the next few slides, I'll talk through some of the elements. I know this is probably a bit of a busy illustration, but we offer some wayfinding in the next few slides just to focus in on some of the key elements. And so where we'll where we'll focus specifically is the green circle there in the illustration to talk about the hub component of this model. We'll talk specifically about the gray circle, the network of community care coordination providers there on the lower left. And we'll talk about the role of funders there up toward the top right. And so we'll focus in on questions about how this model can improve accountability and quality of services, how it changes the way service providers are reimbursed, and eventually, most importantly, how it benefits families. So I'll start kind of talking through it with the next slide. Okay, so here we focus on the hub component of the model. The hub is it's designed as an administrative and an information technology infrastructure that serves as a central organizing point within the model. The hub is not intended to be a large, monolithic, resource-intensive infrastructure. Really, it's designed and it operates in our community and in other communities in our state as a pretty lean intermediary organization with a handful of staff that sort of administers the rules and the resources and the protocols for the model to operate within a community or a region. So I mentioned that the hub serves as an intermediary, or really a broker, sort of between the funders and the payers and a network of coordinated community service providers. We've heard folks in our community refer to the hub as something of an air traffic control, so that might be a helpful analogy. The hub establishes contracts with funders that allows them to invest in achieving the outcomes that they care most about. So, where we've seen a lot of interest among payers and funders is in getting healthier birth outcomes, influencing school readiness among pre-K populations, and even workforce development and job readiness. The hub also lives in between payers and providers, so it establishes performance-driven contracts with community-based providers to deliver the care coordination services that I described earlier. And the idea is that the hub manages a network of community-based organizations that are all using the same care coordination approach to connect individuals and families with the services and supports that meet their needs. And it improves our ability to begin reducing duplication and redundancy of services across providers because the network uses a consistent data system that's introduced and operated by the hub, and it operates within a standard set of practices across the provider network.
And Dave, as you continue to tell us a little bit more about the structure of the hub and how it operates, I do want to remind our listeners that you can send us your questions through the question box, and Mary is monitoring that. So let's continue with your discussion, Dave.
Great, thanks. So again, zooming in on another key element of the hub model, here we focus on probably the most important aspect of the model, which is the network of community-based care coordination agencies. These are community-based organizations that employ staff who act as community care coordinators. And terminology is really important. We found that words mean a lot to folks, and so we've been real careful to use terminology consistently. So when we talk about the individuals or the personnel that are employed within these organizations, they can be community health workers, they can be social workers, they can be clinical providers such as LPNs or advanced practice nurses. So really the system is personnel agnostic. It can work across a variety of different workforce setups, and we're seeing that in our community. The important aspect about the role of care coordination agencies is their ability to be able to connect people with services and supports using the consistent care coordination method that I described earlier. And another note about care coordination agencies is that they agree to serve as a part of a network of other provider organizations in partnership with the hub. So again, it's in a sense we're influencing practice by getting provider partners to agree to play by the same rules, and that's really how the system helps to institute reduce duplication and start to avoid some of the redundancy that we see around services provided by multiple agencies to the same individuals and families. So care coordination agencies are, they contract with the hub to do, as I said before, really what they're already well positioned to do, which is work with individuals and families to assess needs, to provide ongoing support and connections to appropriate services, and to measure results in an accountable way. So to be clear, this model is an effort to elevate the importance of the linkage and the care coordination function within our community. As I said, we have a really robust array of direct health and human services, so supportive housing, out-of-school programming, clinical and community-based health services. So it's not about suggesting that this piece of the work is a replacement for those direct services, but those services are only as effective as our ability as a community to be able to create consistent pipelines for individuals and families to connect into those services. And again, these organizations provide important support and supervision to the care coordinators, to the individual personnel who are working with families, and they benefit from the data system and the structure and the quality improvement efforts that the hub is responsible for instituting across the model.
Right, and maybe you could tell us a little bit about the funders and the payers now and how that works.
Sure. So this has been, you know, a particularly interesting element of the model, both for us and for the stakeholders that we've talked to over the course of, you know, our learning and exploration of this model. I mentioned earlier that the hub acts as an intermediary between funders and between community-based providers. And part of the hub's role is to establish contracts with funders and payers that tie the payment to specific care coordination activities and outcomes that begin to get the results that we want. So the arrows in the document, or on this slide in the illustration, are designed to represent the care coordination protocols, the very specific step-by-step approach of getting individuals and families connected into resources. And along those pathways, there are opportunities built in for reimbursement that incentivize adherence to the model, and then again create increasingly accountable payment opportunities. So, you know, what we've seen in other states and regions is that hubs have established contracts consistently with Medicaid managed care organizations. So Ohio is a managed care state, and we've seen some really interesting partnerships where MCOs within our state are contracting with other hubs currently operating outside of the central Ohio region with a specific interest in getting better birth outcomes, for example. These payers want to ensure that their investments result in full-term healthy birth weight babies. So the hub, in turn, is positioned to be able to pay funds out to its network of community-based providers when they coordinate care and when they achieve the results for their clients. So again, using the healthy birth weight example, community-based providers in this model are reimbursed when they're successful at getting women into prenatal care earlier in their pregnancy. We know that getting a woman into prenatal care in the first trimester as opposed to the second or perhaps third creates a better opportunity to get a full-term healthy birth weight, healthy birth outcome. Providers get the opportunity for reimbursement when they ensure that the woman shows up and attends regular prenatal appointments. Again, that's shown that to create a better opportunity for healthier birth outcomes, and to be able to coordinate care around some of the health-related social determinants. So ensuring that woman is in stable, affordable housing and is, not dealing with interpersonal violence issues or experiencing food insecurity issues, all of which have a bearing on the likelihood of of a poor birth outcome. And this way of being able to do the work is viewed as adding value to the way that payers both Medicaid managed care providers, and even philanthropy within our state to be able to get better, more consistent outcomes.
And so Dave, you know, as I reflect on what you've been describing, I see that the hub is not only managing coordination among services, but also bringing together various systems that help to improve the health of communities. So it's evident of obviously that coordination is key to this type of model. Why are United Way's uniquely positioned to implement a system such as the Pathways Community Hub?
Sure. Well, you know, I'll speak from the perspective of our United Way, but I do think that some of our experiences and some of what we're learning can apply across the United Way network. This slide shows some of the thinking that has kind of guided us throughout our implementation of our new our current strategic plan. We realized early on within our new direction that our aspirations and our capabilities would align really well with this type of model. And as we've discussed, the model relies on some key elements: cross-sector collaboration, the opportunity to increasingly leverage funding across systems, a commitment to addressing co-occurring needs of individuals and families, and strong infrastructure that can be positioned among systems to serve as a shared resource. So when we reflected on our current and our desired situation as a community partner, it made sense that this model fit within that, within that role fairly well. So as this slide depicts, what we observed within our own work is that number one, our work was not entirely aligned with addressing poverty issues. It wasn't designed to do that, and so that was a big shift in moving into our new strategic plan. Our approach to investing and contributing resources into the community was lengthy. It was resource intensive, and it wasn't our approach to the work wasn't as responsive as we thought it needed to be. And so, we were clear about our desired situation, and that we need to be a partner within Central Ohio that is focused on addressing the root causes of poverty, and we wanted to take a more collaborative approach. The slide references collective impact. I'm sure that the many listeners on this webinar are familiar with the formal kind of model of collective impact, and that's gaining acceptance and support within our community. Obviously, we wanted to continue to achieve measurable results, and we wanted to be able to position ourselves in order to be able to catalyze additional investment and influence co-investment across systems so that we can multiply our effect. And so within our more integrated model, in which the hub is a key piece, we realigned our strategies. We've kind of diversified our investment approaches, and we've, as a United Way, as a funder within our community, not only have we accepted the role of operating this hub model within our community, we've also made a commitment to be able to invest into it, so to be able to put resources into the model so that it can flow through the health and human service system that we described earlier. There's a term in here that might be familiar to folks in the United Way system, and perhaps not to others, but we wanted to be able to increase RUM, or resources under management. So we want to be able to influence additional investment into our system so that we can put those resources back into the health and human services system as a funder, as a part of philanthropy. And we wanted to be able to leverage our own strengths and to be much more nimble and agile and responsive in doing the work and bringing partners along with us.
And this has been wonderful. I really, every time you and I have talked offline, I've enjoyed hearing really a lot about how well this system seems to be working to meet the needs of your community. So I really do appreciate you sharing this innovative strategy. And I know it's pretty early on in the rollout of the hub, but are there any lessons learned that you guys have discovered that you could share with our listeners?
Sure, yeah, I'd be happy to. I captured a few of what I think have been the most influential for us on this slide. Conversation with stakeholders goes a long way. I mentioned a large number of individual or small group stakeholder conversations. That's, I don't know, perhaps may sound kind of high to other partners, but literally we spent about a year and a half just having conversation after conversation with partners, both community-based partners, with other funders within our communities, key leaders of institutions, both public and private, and we just simply socialized the model and asked, is this an approach to the work that can add value in our community? And increasingly that approach to us learning about it and really, you know, kind of getting a sense from others if it, you know, would be a value add, along the way that began to build momentum and interest. And so, you know, one of the things that came from that, you know, kind of as we refer to it, the Hub Roadshow, was that you know, folks agreed that this is something that our community should be doing anyway. This is a direction that we should be heading, and it was really important for us to create opportunities for partners to commit. So this is very clearly not a United Way of Central Ohio initiative. In fact, if you look at some of the materials that we've created to communicate this work, our brand really isn't out on any of those materials. And I think that's been important for partners to see this as a shared infrastructure within our community and a shared resource that can help provide solutions to multiple systems and institutions that are really kind of working to achieve similar outcomes. You know, we've seen initiative fatigue in our community, and I'm sure this is something known to others, but in working across sectors and in trying to, you know, sort of go upstream, as it were, I'm sure that's, you know, terminology that's familiar to listeners. It's easy to allow ideas to be seen as yet another thing and yet another obligation or responsibility that my system, you know, my school or my hospital or my philanthropy needs to engage in, and it's easy to have folks sort of push back from the table. And it was really important for us to make sure that folks saw this model and this approach to doing the work as something that amplifies and augments what they're already trying to do, rather than just kind of layer another thing on top of what they're trying to do if they wanted to partner. And, you know, learning opportunities, I kind of shared that at the very beginning of our conversation. We're very much in a learning mode. We're doing this work. It's early on, but we are in an implementation stage. However, we continue to learn and create opportunities for our partners to be able to do that as well, so that they can see themselves in it. So that's been really key. You know, as we get further into implementation of this model, it's really a new approach to the work, and we've had to remind ourselves to be disciplined, not to assume that folks are moving into this work more quickly than we should expect them to be, ourselves included. So understand that this is a model that's based on relatively basic components, but taken together, it's a pretty complex, interconnected way of doing the work that is going to take time for folks in any community to really sort of come along. And don't try to boil the ocean, you know. When we convened a set of community leaders to serve as the advisory board for this work, to have that cross-sector guidance and governance, one of the common phrases that we use is to let's agree on the good place to start, and let's think about where we can make progress, as opposed to trying to be all things to all people. So those are about a half dozen lessons learned that I think have been fairly influential to us.
Very good lessons learned, and something that I'm sure our audience will appreciate. Thank you so much for sharing with us. Don't leave yet, because we do have some questions. We have some time for questions. And Mary, can you share with us what's been populating? We've got about 10 minutes for questions.
Yes, thanks so much. So I've got a long list of them, but one question was, how many years has Columbus had the hub operational, and how long did it take to establish?
Sure. Well, Erica did not overstate. We are fairly new into the work, so we're about 6 months or so into implementation of this model, so it's very new. We've been building and establishing the infrastructure and planning for probably about a year and a half, and so that's been, you know, time focused on vetting things with partners, aligning different individuals and organizations to be supportive of the work. We were fortunate to receive a replication grant from the Ohio Commission on Minority Health, and so the Commission recognized early on the value of this Pathways Community Hub primarily to address infant mortality and birth outcomes, poor birth outcomes within our state. And they were successful in lobbying our state legislature to include funding in our state's biennial budget that the Commission would be able to grant out to be able to expand 3 existing hubs in our state, 3 fairly mature, robust hubs that have been operating for up to 8 to 10 years, and to be able to replicate the model in 3 additional communities. And we were fortunate to get Commission on Minority Health funding in our state to be able to replicate and launch the model in our community, in our region.
Great. That's wonderful. You were able to get that support, and I think it reflects your cross-sector work and your building relationships. So another question here is, does the hub charge a specific percent from grants or contracts negotiated, and is it a standard, and what kind of percentage is that? And then the third part to that is, are earnings the major funding, or is direct funding the largest percentage of the way the hub is funded? So a lot of funding, good funding questions.
Sure. Try to touch on each of those individually. There isn't a standard in terms of the administrative costs associated with operating the hub. There isn't a standard approach to doing that. There are, somewhat consistent ways of doing it, but we've seen some variance across the state. Primarily with managed care providers, some hubs retain an administrative fee that's a percentage of all care coordination activities to be able to reinvest into the hub and support operational expenses. So we've seen that. We've seen, grants that come from philanthropy that don't have a consistent administrative fee associated with them. But the model is such that the hub shouldn't be a large infrastructure for the community to be able to fundraise for and support with separate streams of funding. The financial model is one where dollars flow through the hub from the funders and payers to the care coordination providers with an administrative fee retained to be able to reinvest in the costs to offset the costs of the hub. I think there was one more question in there, Mary. Could you repeat the last part of that?
Mary, you might be on mute.
Oh, sorry. Yes, I was. Are earnings the major funding, or is direct funding the largest percentage of the way the hub is funded?
Sure, thank you. So again, I think that what we've seen is the maturity of the hub is connected to the response to that question. So earnings for some of the more mature hubs is a primary source of revenue to be able to offset operational expenses, but there are also directly funded grants that also support the costs and the infrastructure associated with operating the hub. So it's a both and the model is positioned to be able to function in that way. So what we've seen is that the larger volume of resources and care coordination activity that flows through the hub, the easier it gets to be able to offset operational expenses in that way, because the idea is that the costs to operate the hub remain relatively fixed and don't grow in scale as the opportunity and the volume of services continues to grow. That's part of the value of the model.
Great. And here's a question related to service providers. And have you run into competition or turf issues between service providers? And if so, how have you worked through those challenges?
We haven't seen that kind of issue surface yet, but that perhaps may be because we're relatively early on into it. However, what I would say in addition is that we we, Central Ohio, have the benefit of coming into this work where there's just been really a tremendous amount of growth and evolution in the model. And so what I would reference is that there are national certification standards that have been put in place for the Pathways Community Hub model. And so we've been using that as a roadmap to develop and to build out our version of the model. And one of the pieces of those national certification standards is to be able to establish consistent known policies and procedures that govern how and why referrals are made out from the hub among its network of care coordination agencies. So in terms of addressing turf issues and, you know, identifying the care coordination provider that's best suited to provide care for an individual or family, we have the structure of the national certification standards and the policies to be able to rely on to say that, you know, if you're agreeing to participate as a part of this model and as a part of this network, you also agree to operate according to some of these standards and procedures that we all agree to. So one of those is, again, to provide equitable and proportionate distribution of referrals from the hub to community-based providers, primarily to be able to avoid those turf issues.
Great, great. Another question here is, do you have a centralized site platform where all members can interact with the hub and where the hub showcases monitoring success?
I think the answer to that question is, you know, whether the hub has a data system or a sort of a data platform to be able to coordinate across the many moving parts, and the answer is yes. Again, we're fortunate coming into the work now when we are. There is a pretty robust and a pretty sophisticated system, data system that's in use by all of the hubs operating in our state, and as I said, there are currently 6 online at this point. And it's a system that was really built by the folks who were kind of the architects of the model. So not only is it a well-integrated data system, but it's really designed in a custom way to be able to meet the information technology needs of the program model. So it's an integrated system that's used consistently by all parties in the system. That is hub personnel, care coordination agency supervisors and staff, and then also care coordination providers interacting directly with individuals and families. And again, it's a robust system. It's capable of meeting HIPAA compliance and other federal regulatory information exchange and personal health information requirements. And so, you know, that's a really beneficial tool that we have at our disposal to be able to coordinate within the system.
Mm-hmm. Excellent. And sort of building on that, it seems a lot of good questions about the financial side of it too. In turn, does the hub actually create grant proposals as well as capital campaigns? And the second part is the hub responsible for all the reporting related to receive funding from all types of entities?
Yes and yes. The hub is in a sense a funder. I mean, it is an intermediary between its braided array of funders and payers to be able to pay by way of reimbursement out to its network of care coordination agency providers. So it's designed in a way that it can manage multiple contracts with payers as well as more traditional grants flowing in through philanthropy. And that's what we've seen in terms of the way that other hubs in our state operate. And again, Mary, I'm sorry, the second part of the question.
Yeah, I should ask them one at a time. I apologize. Is the hub responsible for all the reporting related to received funds from all types of entities? So is that centralized?
It is, yes. Thank you, Mary. It is. That is another responsibility of the hub. And again, it has the data system as a resource to be able to do that. So again, I would reiterate that the design of this system is an integrated one. So the same data entry platform that care coordination providers are using and capturing information about individual clients and families in the field is the same data that flows back up to the hub, and it's the same data that's used for reporting and for generating invoices for reimbursement from payers. So it has multiple layers and capabilities built into it, and again, that's why we're really fortunate to be able to rely on that IT resource, because it integrates all of the components of the model that we talked about throughout today's webinar.
Excellent. Well, we do have a lot more questions actually, but as Erica will say, we do have an after chat.
Right.
And so for now, I think we need to turn to Erica to do the wrap up. Thank you.
And thank you, Mary. Yeah, we'll go ahead and wrap up. We started with these reflection questions at the beginning of our webinar, and I hope that throughout the discussion you kind of kept these in the back of your mind and maybe have some answers for them right now. So think about those reflection questions following today's discussion. Please stay connected with us. We have a presence on social media with Twitter and Facebook, and if you have not already subscribed to our e-newsletter, I encourage you to do so, and the address is there on the screen for you. This program is the result of many contributions of several partners, including those listed here, and we thank them for their contribution to our work. So at the beginning of the webinar, we introduced you with this guiding question, and we hope that this discussion has generated some new ideas and thoughts about how social service providers can collaborate more efficiently to help those most in need. I want to thank Dave for joining us today, and to our viewers, thank you for taking time out of your schedule to join today's discussion to learn more about this innovative approach to social service provision. Dave has agreed to stick around for about another 15 minutes to answer some additional questions during our after-class discussion that Mary referenced. So for those of you who are able to do so, I want to invite you to join us for this discussion. Do please go ahead and start sending in your questions via the question box so we can get to some more of those. But at this point, I am going to officially conclude our webinar. So again, thank you for joining us and have a good afternoon.